Okay, it is 12 o'clock on the dot. Good afternoon, everybody. I am Elia Prostowski, the Executive Director of the Rural Collaborative, and you are here because you are interested in transitional care. This is the third Brown Bag Lunch and Learn that we've hosted here at the Rural Collaborative, and I'm going to turn this over in just a second, but I do want to share that we are recording this because many people wanted to listen in today but couldn't. So keep that in mind. And just a few logistics before I turn it over to Melissa. Just as a reminder, these are the first Friday of the month from 12 to 12:50 p.m. These are topics that are selected by your peers and presented by your peers, and it's meant to be interactive, safe, and informal. So this is a rural collaborative safe space where you can talk amongst yourselves, ask each other questions, and if you can mute yourself when you're not talking, but I've spoken with all the folks from Mason and they would love to be interrupted. If you have a question, you could just interrupt. And with that, I am turning it over to you, Melissa. Hello and welcome.
Thank you. Very happy to be here. We always love to participate in any collaborative event. We do a lot. Actually, part of our program, we worked with another rural hospital that really gave us a lot of information. So I won't steal Rob's kudos. I'll let him get into that. Just a little bit of background. So 2018, 2019, we were experiencing rather low census. And so we were having to low census nursing staff. We did lose a few staff members because we, they couldn't get their hours. So we were brainstorming on how we could create a program that was a little bit more sustainable and take us into the future. And I know several of the collaborative hospitals already have transitional care. And so we felt like that was a good fit for us. We have had difficulty in the past with patient placement, especially into long-term care or getting the home health care that they needed. So we did do a business analysis. We partnered with Elevent, who are phenomenal. They are actually a Mayo company, and they helped us, build the business case. They helped us with our timeline for implementation. And again, I'm going to let Rob Bennington, who led this project for us, he's the direct care manager. But just a few things you can expect out of today's session. On the next slide, we're going to talk about how we started the Transitional Care Program. I just gave a little bit of background. Rob will dive deeper into that. How we engaged our providers, the business case. We have Brad Becker, our finance director extraordinaire. How we prepared and trained the staff, what the transitional care certification looks like in that process to get certified from Medicare and CMS, the inclusion criteria, accepting transfers from other facilities. That was a hot topic when we were developing this.
Yeah.
Transfer, feel a little overwhelmed.
Mm-hmm.
And how we got our community message out about our transitional care program. So I am going to turn it over now to Rob Bennington, our Director of Acute Care Services, who led the transitional program.
Thanks, Melissa. And just a reminder, if you're not talking, to please mute yourself. If not, I will find you and mute you. And I don't know if I have the technology to unmute you if I mute you. So just a friendly reminder, and over to you, Rob.
Okay, thank you. Again, yeah, this is Rob Bennington. So Melissa, my Chief Nursing Officer, introduced this topic to me in 2018 because like she said, in 2018, it was a tough year for the staff. Census was down a good bit of the year, and staff were having a hard time getting work. So it was a great thing to start. We started talking about it in 2018, but really didn't get going too much until 2020. That was our our planned transition year that we were going to develop the program. And we initially intended about a 12-month build up to start the program. But the way things went, we ended up having to crunch that timeline into about 6 months. But it still worked out fairly well. We started engaging the providers right away. So I got introduced to it, as well as our lead hospitalist, Dr. Lindahl, got introduced to it in 2018. And this is where I want to put a kudos into Skyline. We did a visit down to Skyline Hospital, and Diane Matthews, their chief nursing officer, was so accommodating. Gave us a tour of the hospital, their swing bed program, shared everything, their program documents with us, policies, and we got to talk to a lot of the staff down there and just see exactly what is required for the program. So that was really nice, and it was really good to get our hospitalist on the ground floor. So he was able to communicate that out to the rest of the hospitalist group that we have. And then from there, like I said, we also engaged Alevant, which is a good resource for development of the program. They helped us with policy development, all the regulatory requirements, really walked us through every step of the way as far as what program documents we needed, pitfalls in the development of the program, and then helped with the staff training piece. There's Alevant actually has a whole lot of education that they can provide. So we were able to partner with them through the whole development process. And then we engaged pretty much the entire team right from the beginning. We started developing program documents in June, I believe June 30th of last year. And then we have a pretty collaborative team here, and I got a lot of help from our care coordination team, from finance and physical therapy. The development office was gung-ho right from the beginning. Thanks, Jen. So it really was a team effort in developing all the tools that we needed. Really had to start with, as far as a business case. Is Brad Becker still on the line here?
Brad, are you here?
Yep. Sorry, I had to unmute. I was following instructions. Yes.
No, that's fine. Using good change management strategy, we had to share with the team exactly why we were doing it, and our finance team was instrumental in helping us develop the business case for creating that sense of urgency to kick the whole thing off. And Brad, did you want to talk a little bit about the
Can I
business?
just add one thing before
Sure.
Brad talks? I just wanted to emphasize, we were set to do this back in March of 2020. We were all ready. We were getting the meetings together, and then we all know what happened. So our 1 year timeline actually shrank to 6 months, and this team really did do a phenomenal job making that happen. So go ahead, Brad. Sorry.
Yeah. So again, this is Brad Becker, Senior Director of Revenue Cycle at Mason Health. So really, in terms of, the business case, it's looking at obviously our available census, because you want to make sure that you have the capacity, because once you build out a program, the swing bed count does, fall within your 25 bed capacity. So you don't want to have a situation if you're typically starting to, push up against your 25 bed limit. Of course, now with COVID and other dynamics, we've had some very, very full houses, as Mel and Rob can certainly attest to. but it's looking at that. And then again, obviously, as a critical access hospital, the cost report analysis, which we use Withly, and of course they did an extensive analysis with us, and then worked with actually our CFO Rick was very involved, and Ruth Varela, the finance director, and so did the thorough analysis. I myself had experience at another facility where it continued to prove itself out as a valuable addition to our continuum of care from both a clinical and a financial standpoint. And certainly having the Medicare cost-based reimbursement helps substantially in looking at the overall analysis. So. And I'll pause at this moment.
Well, I did want to add, as far as some of the financial reasons why we were so encouraged by the success that other facilities have had. The swing bed program can really help with some of the tough cases that we already had at the hospital. So we've had some placement issues. We've had some difficulty getting some patients out to long-term care. And so I think all we were able to do for those is get some kind of daily administrative rate as far as reimbursement. We've had, especially with COVID situation being what it was, we've had a lot of difficulty finding adequate places for the patients to go. So this is another option for us to be able to keep the patients. And the swing bed rate, CMS allows us to charge, as a critical access hospital, it allows us to charge 101% of the cost of care for these patients instead of a much lower daily administrative rate. So it really made sense to us that if we're going to, have these patients here anyway, past their acute care stay, once they no longer, really qualify for acute care, then we can, get adequate reimbursement that covers what we're providing for the patient.
Rob, as far as preparing and training the staff, do you want to talk a little bit about that and how Elevant was pretty key in getting education to staff? And
Yeah,
they'll actually continue to do so. So the Elevant is about a 3-year contract. So they help with the implementation the first year, second and third year, they continue to work with us and do any outreach that we need to do for area hospitals if we want to transfer in. And they also continue to provide education. So Rob, do you want to talk a little bit how that looked?
Yeah, so Elevant has a lot of online modules, and they actually they have their own learning management system. We actually put all of our acute care nursing staff into their system so they can get into these learning modules that Elevant has for us. In addition to that, though, because we had a shorter timeline, we expedited as much as possible preparation for the staff, and in doing that, we actually used staff meetings. Now we have on the med-surg floor, which is where a lot of the swing bed patients are going to end up staying. We have a supervisor, Carol Williamson, who's done just a tremendous amount of the legwork and boots on the ground kind of stuff in training the staff. She prepared cheat sheets and education for the staff, and has done staff meeting presentations, and she's worked with the staff directly at the bedside. But now we've only had 2 swing bed patients so far, but she truly was working directly with the staff through all of those, through both of those patients, just to make sure that everything that we needed to have in place was in place, and that the staff felt adequately prepared.
Okay, our Mason friends, we have a question from Deborah. I'm thinking this is Deborah from Forks, about acuity levels. Can you talk about the acuity level, what the acuity level has been for your transitional care patients, and are you taking complex wound care or ventilated patients? Or do you plan to? Because I don't think everybody knows how new your program is. Maybe you're not now, but you're planning on it.
We aren't, and we don't have any plans to take really complex patients at this point, particularly not the ventilator patients. We just don't feel like we have the capacity to do that. And the two patients that we've had, the first one was, I'm gonna tap into my med-surg supervisor here, Carol Williamson.
CHF.
It was CHF, and that's what it was. His family felt like he wasn't quite ready to go home, but they were adamant that they didn't want to go to a nursing home. And it's a family that's actually well known to us, and so he was actually our first swing bed patient. And do you remember how many days he was in swing
He
bed?
was here less than 3 days, and he just did physical therapy, and he got better faster than we anticipated.
Yeah, so I don't know if you heard that, but he was here for 3 days, got some physical therapy, and then improved more rapidly than we thought, and was able to go home in a few days. The second swing bed patient we had, unfortunate victim of stroke with some mobility issues, occupational therapy needs, speech therapy needs, and so she was here for a couple of weeks, I believe.
Yeah, 13 days.
13 days, yeah.
Rob, do you want to talk a little bit about the balance issues that we're having between the acute care and the transitional care? That might
Yeah,
help frame, kind of what our conundrum with that piece, because the census on our med surg floor is usually around 12 to 13. So, Rob.
Yeah, we were really sensitive to the needs of the community, in that we feel like the acute care beds that we have are actually more valuable, because we have, obviously we have the resources that we need to take care of acute care patients, where the swing bed patients really often can be cared for in a nursing facility. So we've really had to balance making sure that we don't take up an inpatient bed, a critical access bed. We're only allowed to have 25 inpatients, and to swing a patient over, we have to take one of those inpatient beds and make that a swing bed, and that takes away from our capacity a little bit to care for acute care patients. So we're really sensitive to that, and we try to achieve a nice balance. That's going to be our philosophy going forward, is that we recognize the value of the acute care beds to the community members that we have. We would not want to see a swing bed patient take an inpatient bed that would then force some other community member to have to leave the county for their acute care needs, if that makes sense. So trying to always balance that moving forward. That's going to be our philosophy. So
Then I can talk a little bit about the transitional care certification. Our regulatory agency is DNV. And so we're partnering with them now to actually complete the survey to get our certification. A few caveats to that is they need they need 4 closed charts and 1 actual patient at the time they do the survey. So we've had a little bit of difficulty being able to achieve that, especially right now with the active pandemic and how high our census has been, to be able to especially take transfers from other facilities so we can meet that 5 patient threshold. And they're very understanding with that. So we've just sent them, email communication saying we're not ready yet. And so it's very smooth and very easy. And Elevent has helped us walk through all of the CMS requirements. So we feel like when we do get the survey, we'll be ready to get that certification. So
yeah.
Are there any questions up until now? or
Yeah,
any-
questions. And also, I think some of you have transitional care programs up and running. So questions and also like suggestions.
Yeah, I would love to hear if any of the facilities out there were anybody was on that was there during the certification, if there were any surprises, things that they looked at, or things, advice that they might have, because we haven't done our certification yet.
I'm not seeing anything in the chat either.
Okay.
I wonder if you want to talk about the either question 6 or question 7, the
Yeah.
transfers and the communication.
There's also this inclusion criteria for the program. I don't know if you want to go over that really quick, but you know, obviously patients have to have a skilled need, just like they have to have for skilled nursing facility placement, either a skilled need or physical or some kind of therapy need. For skilled nursing, they have to have skilled nursing needs that are 7 days a week. If it's therapy, they allow it to be a 5-day-a-week therapy session. So,
Hey, Elia, this is Larry, Ocean Beach. I'll jump in, but I'm probably the last person to be speaking to this.
Okay, great. Thanks, Larry.
So we do have a swing bed program. We've had it for years and years. Basically we have 8 staff total beds in the hospital. And typically, you know, 2 or 3 are swing beds and 3 or 4 are inpatients. Throw in an observation here and there, a surgery patient. I would say that maybe a third of our patients or half of them are internal transfers to swing bed. And the rest come back to us from strokes or traumas that we sent to Legacy or OHSU. So that's kind of our source of patients. I'm not sure how to answer the question about certification. It just is. And I assume that when we get our Medicare survey by the state that gets looked at. If you need more information, you know, Deborah Barrett, our inpatient nurse manager over that area, or Brenda Sharkey might be able to provide additional insight.
appreciate that.
So Larry, this is Brenda. Do you want me to jump in a bit?
Sure. Just don't undo anything I said, like in case it was wrong.
Absolutely not. I would never do that.
I know. I appreciate that.
So basically, just to give you, getting ready for your survey, and I've come from a DNB hospital and in the past, and I agree they're awesome. I appreciate their process and the way they do things. I would really focus on, and maybe you already are, your activity program, because that will be something that they will look at. And the other thing is your policies, and probably the company you're working with has already done that, but they very much focus on the vulnerability of the patients, of these particular patients. And that includes, you know, the vulnerability of abuse and neglect. So really look at that policy and make sure that your staff are trained to the policy, because that will be very important to them.
Thank you. That's super helpful.
I think Deborah from Forks, did you want to?
Yeah, I'll jump in here as a DNB quality person who's worked with recertification and certification for swing beds. Some of the issues from your quality standpoint are the fact that your appendix W with the requirements for swing bed will refer a lot to the appendix double P, which goes to the long-term care. And so you got to kind of pull this back and forth and back and forth. Which one am I on? you were right on with the activities, with the rights and responsibilities of your swing bed patients, that they have the handout that says what their rights are, that you're making sure that they're getting the correct amount of physical therapy. I think probably one of the biggest pushbacks we had in our area that kind of bit us occasionally when the DNB came through was the fact that you really have to wrap your head around when they're inpatient and they're going to swing bed. You have to stick in your head that you're loading them into a virtual car, you're driving them around the block, and you're readmitting them. So your provider has to do a discharge summary, your provider has to do all new orders. You need your assessment, your nursing assessment has to be redone, and that's frustrating because the patient didn't actually leave the bed and they're still there and they didn't change from 10 minutes ago, but they did. It's a new admit, and so that caught us up a lot. So make sure you have that. I highly recommend you pull out the DNV section on swing bed and just walk through it. Do I have a policy for this? Do I have a protocol for this? And take each step by step. And like any good ISO document control, if you've got it there and you can show that you're doing it, you'll be fine. You'll be great.
Hey, Deborah, can I ask you a question really quick about the patient rights document that you hand out? Do you have them? I know it's a small detail, but we pondered over it. Do we have the patient sign for that? Or how?
Yes, I'm going to ask Angie to unmute and tell how she designed that form.
Hello. Well, I didn't design the form. My predecessor, Kelly Thompson, did. So we do have an actual packet that patients or their durable power of attorney sign. So our social services department, case management department, goes physically in, explains to the patient, you're going to swing bed. There's nothing wrong with your bed. It's not actually swinging. Here is the reason why we're doing this. And then we explain, and there's about 5 pages that the patient signs. And that's what we have so far.
Okay. Thank you.
Thank you, Deborah. Thank you, guys.
Yeah, we believe in begging, borrowing, and stealing. So if you want any of that, we'll send it out.
I would love that. Thank you.
Thanks, Deborah. Thanks, Angie.
I've done a fair amount of all 3, beg, borrowing, and stealing so far. And DNV, just to add what a comment that they had, we talked to somebody about this already. They said that they refer to the NIAHO standards. And so that's my next task, is to review everything we've created so far against the NIAHO standards to see. And I think it probably would be a copy and paste from at least the Appendix W, but
It is, with a little bit of their interpretation on top. And I will tell you that I'm lazy, so I take the NIAHO standards, I cut it apart, and if it's a section that goes to social services, I send it to them and say, this is yours. And if it's for dietary, I send it to them, this is yours, so that I don't have to do the work.
I got you. Work smarter. All right. Thank you.
So Jen, Cheryl, anything you want to add?
Yeah, hi, this is Cheryl from Rehab Services. I'm the Director of Rehab here at Mason Health. And can you hear me?
Yes.
Yes.
Yes, okay. So as we were preparing for this, training the therapists, kind of just getting them informed of what was coming, and basically that transition of the readmit was important, because they've already done an evaluation if it was a patient that was in-house, but because like they drove around the block, as said, they have to do another evaluation, and emphasizing that this evaluation, they're kind of setting new goals, because most inpatient acute care goals are for safe discharge. But now they're expanding upon those goals and working with the patient to come up with more usual activity functional goals. So it progresses them back towards their prior level of functioning. And the therapists were happy, to be able to add this program. And I would add that one of the questions that the therapist had initially was, okay, so our acute treatment typically happens in the patient room or in the hallway. For these patients, we're going to be progressing them a little bit more. We needed to come up with a process to bring them down into our department and making sure that the patient was getting dressed each day and able to participate in therapy in a outpatient setting. Wondering if the other people who are on the call that have been doing transitional care, how does that space transition happen with your patients? Or are you seeing your transitional care patients in their rooms, or are you taking them to the therapy department?
So here at Arbor Health, we have separate hallways for our COVID patients and our non-COVID patients. So our patients for transitional care have been leaving their rooms while wearing a mask and ambulating in the hall that's deemed non-COVID, and there's no risk of them coming in contact with those patients.
So in the hallways, but not taking them to an outpatient area?
This is Deborah from Forks. We can't take them to the outpatient physical rehab because the only way to get there inside the building is through our long-term care, which is transitioning them, which is walking them through somebody's home. Otherwise, they'd have to go outside, and the weather is not friendly for that most of the time.
Okay. So yeah, currently we are able to bring them through the hallways and the elevator because our department is within the hospital. In the future, our department may not be in the hospital. So then, yeah, it's going to be trying to figure out how to do that within the building will be different. But this second patient that we had that was the stroke rehab, she was gung-ho, and we did bring her to the department, and it was a positive experience for her to be able to use some of our therapy equipment and feel like she was getting back out into more normal life, not just in the hospital.
Could I jump in here from Whitman Hospital in Colfax?
Absolutely.
I'm Susan, and our therapy manager, Krista, can add to what I share, but I'm not sure when we started our swing bed program, but it was before 2013 when I joined the hospital. And we looked at how many patients we had last year. It was 68. And then so far this year, we've had 25. We're certified for 5 patients. And we do prioritize our inpatient clients, offering them a choice whether to transition to the swing bed program versus transition to a facility, giving them that choice. But in terms of our therapy department's very flexible, and our patients have been able to participate in therapy on the med-surg floor. They have a gym on the med-surg floor. There's steps that they practice on the main floor. And there's an activity room that is probably underutilized, but my goal, and I think our goal, is to adapt a comfort care family room to have a multiple purpose as a therapy apartment suite to help patients practice their daily activities of living in a more apartment setting. So I'm excited about that, and we need to work through our administration in order for that to take place, but I'm hopeful about that. And our patients also, our swing bed patients also go down to the outpatient therapy gym to utilize the exercise equipment there. What am I missing, Krista? Would you like to say anything?
Well, unfortunately, during COVID, I have not been able to let patients on swing bed come down to the outpatient gym because of my capacity restrictions. So that's been a challenge that we've had because we have significantly different equipment, certainly in our main gym as compared to what we have on the MSU floor. But for the most part, we try to create, we've had patients outside practicing fly fishing. Really, it's looking at what are those occupations and how can we help them to be ready to do those successfully at home. As Susan mentioned, one of the things that we feel is missing and we really like is that apartment where we can have the real life setup and try to make it as real as possible. We contrive a lot of things, but it's not always translating into what the patient feels is real life. So it's a
Krista and Susan, which hospital are you from?
Whitman Hospital.
Okay.
And we do.
Yeah, the apartment sounds wonderful.
That does sound pretty cool.
It's been a dream. If you've never been to Northwest Hospital over in Seattle, they have the most beautiful, easy street. If that was my ultimate wish, that would be it. It's incredible.
I'm working on my Fund a Wish program for our members.
Our physical rehab department wants a portion of a car so you can practice getting in and out, shutting the door.
Oh, awesome.
Yeah, we have a facility that's an inpatient rehab facility that's in Spokane, relatively close to us, and they have part of an airplane, a bus, a car. They have a little movie theater, a little grocery store, multiple changes of surfaces. So as a therapist, that's heaven. And the one at Northwest Hospital was it's even bigger than that. It was amazing to see all the different surfaces, the levels, the ramps, the steps, all of the things you encounter in life.
Huh. So there's a question in the chat from Diane, and I wonder, Jen, if this is when I should stop sharing, if you wanted to share your screen.
Sure, happy to do it. Absolutely. Hi, everyone. I'm Jennifer Capps. I'm the Chief Development and Communication Officer for Mason Health. I'm going to screen share, so bear with me just for a quick second. Okay, I think that worked. Can you guys see my screen?
Yes.
So, kudos to Rob and his team. He was able to engage.
There's a lot going on your screen right now. I don't know if you want to choose.
Yeah, so I've got a couple of screens up right now. One is some social media information I wanted to share.
Okay.
And the screen here has got our website.
This is a nice insight into how your brain works, Jen. Love it. I love it.
Hey, I'm an open book. It's all good. So I was saying kudos to to Rob and his team, because they were able to engage with, the marketing team, me, and our action plan for the district really was great because it allowed that quick team integration so that we're all collaborating and so that we're all on the same page with the implementation. And so there's lots of outreach, which is, traditional media outreach, which is like, our Scope magazine, which I'll show in a minute. To our website, to interviews that we've done, and also in the digital space. So I'll start with our website. So here on our website, this is our transitional care website page, and it's actually under services. It's one of our service lines. And the architecture of the website is created so that we kind of have this really cool hero image. We give a little bit of a summary. And, at our organization, we really want to showcase our own staff and our own people so that the patients and community members will see who's actually going to be treating them when they come to our facility and our organization. And, our team worked really closely with Rob to really make sure our messaging was appropriate for our mission and for the organization and our community partnerships, because we're really clear that we are not competing with the other skilled nursing facilities in our area. We are collaborative in nature, and part of our strategy is partnerships and outreach. And so we wanted to be really clear that we were trying to augment what the district is able to offer for the community and not take business away from other local businesses. And again, of course, this was in Elia's awesome presentation, Cheryl and members of her team. So we have that core messaging, and then we talk a little bit about what our services include. And then what's really cool is that we actually worked with Rob and his team to actually create a brochure. So we really wanted to make sure that, again, it was, on brand, And then it had our key messages, and that we showcased the people that are actually going to take care of our patients from, from our own team. So that kind of covers the website. And of course, any of this, we're on Facebook, Twitter, Instagram, and LinkedIn. So we have tons of information out there for folks to kind of see and take a look at. And then this is our latest issue of Scope Magazine, which goes out to 25,000 households in our service area 4 times a year. And in the development of our collateral, we really wanted to make sure we showcase the Transitional Care Program, and we're having consistency in our messaging. I'm sharing, so it's a little bit slow right now. I'm going to kind of flip through here really quickly. But you'll see in our magazine, we cover the Transitional Care Program. And I'm going to zoom in so you can kind of see it here. And I'll center that. So here again, we make sure we had, a picture of Rob, who's the lead on the project, and all of this content was revised a little bit to be appropriate for Scope Magazine, but it also was also consistent, and also messaging around our community partnerships was really important too. And in addition to that, we have a really good relationship with news media outlets in our area and in Thurston County. And so part of our communication did also include Thurston Talk, which is an online news outlet, as well as our local media, radio stations, newspaper ads, those sorts of things, to also kind of promote, this new service line. You can see we got some really good reach on Facebook. And then again, some of that similar core messaging that we wanted to share out with the community as well. And then last but not least, the social media space. So all this is kind of coordinated and cascaded, in succession in our, in our social media strategy and plans. And so here's our social media posts that we had, and we linked back to Thurston Talk. And we love it when things go right deep to our site, because that really helps with search engine optimization. And this post reached over 2,700 people with almost 300, people that have reacted, commented, those sorts, commented on the post or interacted with it in some way. And of course, that cascades over to Facebook, Twitter, Instagram, and of course, our LinkedIn page too. So I will pause there for question or comment, or questions that I can possibly answer. Hearing none, 8 seconds. So, hey, so if you have questions, feel free to reach out. I'm happy to help.
I really enjoyed what you just shared, and how you're advertising your swing bed program on your website. It re-energizes me to have more information available on our website about our swing bed program, and finish of the brochure that we've started and haven't actually completed yet, just because of how life and you get busy and things. So it really does encourages me for our team to put more out there on our website. So I thank you for that. And if any of you would be interested in seeing our packet that we provide to patients about the patient rights and responsibilities, we'd be happy to share that. We've got I think we have a really solid internal referral process in place that utilizes a multidisciplinary team and a pre-planning document where all the disciplines sign off.
Their swing bed, their transitional care program.
Okay, we got somebody not on mute. I think that might be Tabitha and Carissa. Sorry, keep going, Susan.
I'm like, do we advertise better?
I just wanted to share that this multidisciplinary pre-planning document has been really useful, because we literally hear from each discipline, from pharmacy to therapy to speech, from the business department, UR, social work, respiratory, everybody. And if people aren't recommending swing bed, feeling the patient isn't appropriate, they'll share their justification why they feel that way and are making that recommendation. But we have everyone sign off on that document prior to accepting someone into the swing bed program. It's very collaborative, and it involves all the disciplines, including nursing. So that's been really helpful, I think, in including everybody in the process. So just reach out to us if you have any specific questions, and we'd be happy to share.
Susan, can I, and this also goes to others, I think, Deborah, you offered to share some stuff. If any of you have offered to share materials, if you could send those to Heather, and Heather, will you write your email in the chat? And then what we'll do after this is we have the roster of everybody who is participating today. We'll send that out. So you will basically have each other's emails, because we get that a lot. Like, it's like after these calls are over, you're like, who was that, person from Whitman or Skyline? And you'll get everybody's emails and names and all that, and you could reach each other directly as well. So if you send that to Heather, we'll get that out. You'll also get the link to the video that you could share with people who weren't able to make it today. Thank you so much. Is there I know we only have 5 minutes left, and I do want to do a quick poll before you guys all jump off. I want to see, Melissa, is there anything else that you want to say? I think you must be feeling like a very proud mama right now. This program is pretty amazing. Is there anything else you want to share? Questions you want to ask? Words of wisdom?
No, I think my team probably spoke for itself. It was pretty amazing to see them be able to, to do this in the midst of a pandemic. So
it's incredible.
Again, yeah,
yeah,
really.
6 months.
Anderson is
6
our
months.
citizen.
What I would like to do before you all jump off is launch a poll, and so hopefully you're getting the poll now. And what we're trying to do is get ideas for next month. This was by far and away, I think, the most interactive lunch and learn that we've had. So we're learning a lot about what you guys want to talk about. I'm hearing you're tired of talking about COVID, which I totally understand. So if you could just respond to this poll and let us know what you're interested in next month. If none of these interest you at all, and you're like, Elia, you like missed like wrong solar system, just send Heather an email and put your topic in there, and we'll make sure that we get these going next month. And then what we'll do is we'll reach out and beg, borrow, and steal to find another volunteer. Mason earned their collaborative member card today, so it won't be Mason, but we'll find somebody else for next month. So while you're filling out that poll, I do just want to share that next month the Brown Bag Lunch and Learn is April 2nd, and it will again be during lunch. If you want on the list to automatically get the invitation, just email Heather. There's her email right there. And I'd like to close just by saying how much gratitude I have for Mason, and also Skyline and Whitman and Forks and Arbor, all of you who leaned into the conversation today to share. I can't tell you how great that feels that these might actually be helping. So thank you all very much.
Thank you. Thank you, Elia. Appreciate it. Thank you.
Enjoy your weekends.
Thank
Thank
you.
you, everybody.
Bye.
That was great. Bye.
Bye.